So I'm just going to do some introductions to start here. I'm Dr. Christopher Earle. I'm a psychiatrist here with NLHS and an assistant professor in the Department of Psychiatry. Our two other speakers here, I'll just introduce in the order there on the slide. Dr. David Gardner is in the back. He's visiting us from Dalhousie University, and he's a professor with the Department of Psychiatry there. And Dr. Sheila Garland is here from MUN's Department of Psychology, where she's a professor. Without further ado, I'm going to introduce Dr. Gardner to talk about why we're here tonight.
So the reason we're here is we actually got some money to be here. That's the honest truth. So we did a clinical trial a few years ago, and the clinical trial seemed to work out. And I'm going to tell you a little bit about that clinical trial. And we applied for some funding to go around Atlantic, Canada, to tell people a little bit about the trial. But it's kind of a sneaky way for us to come. So you do have to listen to me tell you a little bit about research, but it's a sneaky way for us to actually get to the heart of things. And the heart of things really is about the overuse of sedatives and the underuse of what is first-line therapy, or the better therapy, the better approach for the management of insomnia, especially chronic insomnia. Okay, so this is what we knew a few years ago, and it's a report by the Canadian Institute for Health Information. So they put out these reports every now and again, and this report is specifically focused on tests that we use in medicine and medications that we use in medicine that are kind of overused or overdone. And I just want to move right into the focus of tonight, which is the overuse of sedatives across Canada. So what you're seeing in this slide is the rate of people 65 and older who chronically take sleeping pills. So in Saskatchewan, the proportion of people 65 and older who chronically take sleeping pills has gone down from that number. It was 5.4%, and now it's less than that. In British Columbia, it's also less now than it was, 6.7%. If we keep going east, you start to see some changes once you get to Atlantic Canada. So I live in Nova Scotia. 14.1% of people 65 and older are taking sleeping pills, prescription sleeping pills, chronically. If you live here, it's around 17%. And if you live in New Brunswick, where we did our research, it's almost 23%. So those are really big differences from one place in Canada to another place in Canada. And we just actually looked closer in New Brunswick. So we went down to sort of a health region and we looked at the specific numbers, and there's very big differences, 11% or 10% in some regions, more than 40% in other regions. The highest number was for females 85 and older in this one corner of New Brunswick, where it was 60%. I can't tell you what it is in different parts of Newfoundland because we haven't looked at different parts of Newfoundland, but we have seen some really large variations from the research that we've done. Over the years, 2014 to 2020, Newfoundland and New Brunswick have something that some of the other provinces don't have. Yes, they have higher rates of use, but what do you notice about Saskatchewan and Manitoba and Alberta, Ontario? What do you notice about their rates of use over time? What about here? It's not going down. We have a comfort with using sedatives at a much higher rate than we see elsewhere in Canada, and that's not changing. And I'm concerned about that. So I'm not the first to come to Newfoundland and talk about the overuse of sedatives and the concerns related to sedatives. So there was a program, and it's still available on SaferMedsNL. So you can watch these videos. They're very short. They're 15, 16 seconds each. Sleeping pills can cause confusion, sleepiness, and impairment. And then there's this one. Did anybody see this video where you're driving and your pills are impairing you? This is worth watching. 15 seconds with a jump scare at the end. So we have been sharing information about the effectiveness of sleeping pills and some of the concerns about the sleeping pills. So how effective are the most effective prescription sleeping pills? How effective are they? So if we look at a specific Z drug, so zopiclone might be a name familiar to some of you. That's Canada's most commonly prescribed sleeping pill. And we compare it to taking a sugar pill or a placebo, you will get to sleep 8 to 16 minutes faster based on well-designed research. That's what it's getting you in terms of how much faster you're getting to sleep. It was actually measured to be something like 45 minutes to an hour. But if you take a sugar pill, you're getting to sleep faster because you believe you're taking something and you're regulating your sleep already because you're focused on your sleep by about 30 to 45 minutes faster. So the sleeping pill's adding to that benefit, but not by a lot. And then how much longer are you sleeping? You're getting from all the way of 5 minutes more sleep up to 23 minutes more sleep on average. That's the benefits that you get. The risks are really important. So falls. Injurious falls overall are increased 60%. Fractures overall are increased 66%. Our study in New Brunswick just showed these rates in New Brunswick to be higher. So it was more like 92% increased risk in fractures and a 72% increased risk in hip fractures with taking sedatives, prescription sedatives. There's other complications that are associated with taking sleeping pills versus not taking sleeping pills when you get a viral illness like the flu or COVID. I would say the most important factor that gets people's attention is their effect on memory. We know that specific types of sleeping pills make it so that you can't remember what you did after taking the sleeping pill. Some people talk about, I drove to work and I couldn't tell you what directions I went. I couldn't tell you how I even got to work because the effects can last into the morning. There's studies that really do a good job on evaluating how it affects your driving. Canada's most commonly used sleeping pill, Zopiclone, affects your driving 11 hours after you take it. You take it at 11 at night, you get up in the morning and you go driving. 11 hours after taking it, your driving impairment is equal to the impairment of a blood alcohol content of 0.05 to 0.08, which is when you lose your license or get charged. And then there's also the concern of quite a few of these sleeping pills are hard to stop. They're habit forming physiologically and for some people psychologically. So what are the treatments that are available and recommended for insomnia? Sleeping pills is second line therapy. First line therapy, which Sheila is going to talk to you about, is cognitive behavioral therapy for insomnia. Hopefully by the end of this evening, you'll be more familiar with it. So Sleepwell was developed to help people become aware of sleeping pills and some of the issues around sleeping pills, and to help people become familiar with CBT-I and how to access it. Sleepwell is a website. mysleepwell.ca is the website you need to go to for accessing it. You'll learn about sleeping pills, and there's a quiz for you to make it interactive, and also you can click on this and learn a little bit more about the dangers or the history of sleeping pills and how we got to where we are today. And then there's guides on how to safely stop sleeping pills. So we wanted to see if we could do something very simple and effective for helping people reduce their use of sleeping pills. One option that's been used a lot is to train physicians and pharmacists to help their patients stop sleeping pills. Another way is to let the patients know about how to do it, and then they can go to their physicians and pharmacists and say, let's work together. We did the latter. So we're trying to go directly to the patient. So the intervention that we did is called a direct-to-patient intervention. So I'll come back to that research. If you want to know about CBT-I and you want to have resources to help you, support you through the CBT-I process, the Sleepwell website has those, and it also has recommended programs for CBT-I. Most of the time, the tips are something called sleep hygiene, and that sleep hygiene might be helpful for people who do not have long-term sleep problems, but just have a bad night or two every now and again, and this is something that they can work on. So sleep hygiene has a place, but it's not usually all that beneficial. This list is an introduction to some of the components of CBT-I. So think of it as a welcome to CBT-I, and you can see what you're going to be involved in doing by working on the tips that are on that list. And the sleep diary is there. Do you want to know your sleep numbers? Do you want to see your sleep patterns? This is the cornerstone of CBT-I, is filling out a sleep diary. It's very simple. If everybody here goes home and fills out that sleep diary for the next week, you probably are already on your way to improving your sleep. All right, so here's the research part of the evening. So YAWNS NB was a study that we did in New Brunswick. YAWNS stands for Your Answers When Needing Sleep in New Brunswick. We randomly allocated over 500 individuals to receive a package we call the Sleepwell group. Another third of the study got the Empower package, which had been studied before and showed that it helped people reduce their use of sleeping pills. And then the other group had to wait. So people came into the study, these packages were mailed out after an evaluation or assessment of their sleep and a few other things, and then we did absolutely nothing for them. We mailed the packages and did nothing for them. And we called them back in 6 months to find out, how's your sleep? How are you doing in terms of taking sleeping pills? What's your quality of life, anxiety, your frailty, a few other measures to see how things were going. The people that came into the study were on average 72 years of age. This is probably the most important number. Their duration of sleeping pill use, prescription sleeping pill use, was more than 11 years on average. And about a third of them had had a fall in the previous year. The package that we sent out, that was the Sleepwell package, efforts to have you reduce your use of cigarettes, you use all sorts of tactics. We call those behavior change techniques. Physicians are supposed to wash their hands between seeing patients. Some behavior change techniques were used to help physicians to remember to do that every time. So some of us don't necessarily always put the seatbelt on, and now it's something we do. That was a behavior change series of techniques to get people to be comfortable with doing that. So in this package are a bunch of behavior change techniques to have people go, 10 years of sleeping pills. Maybe I should rethink my long-term use of this. Maybe I should come up with a different plan and go talk to somebody about it, or potentially even do it on my own. So it's embedded with 27 different behavior change techniques to try to have that change to a healthier preferred behavior. These are some of the pages that are in the first booklet, which is How to Stop Sleeping Pills, with a guide of how to do it in the booklet. And then it's not that we're taking something away, it's that we're recommending something better, which is cognitive behavioral therapy, which is also included in the second booklet. So that was the Sleepwell package that was sent out. These are the results. The package, remember I said the package and nothing else? 26% of people receiving Sleepwell completely stopped their sleeping pills by 6 months. months, and another 20% reduced their sleeping pill use by 25% or more. The booklets encouraged the recipients of the package to go see their family doctor, their prescriber, whoever that was, and their pharmacist. Many chose to do that. Others chose to do it on their own. So they were given the information of how to use CBT-I's techniques, some of the techniques, or get access to a CBT-I program in full, and also how to safely, gradually reduce their sedative use. This is what we call a very simple intervention that's scalable. We could do it across the Atlantic Canada. We could share this information to help people rethink their use of sleeping pills and access and use of CBT-I. One of the questions in follow-up was to assess sleep. And we saw that people were sleeping better in the Sleepwell group, not in the other two groups. So we know that the intervention itself didn't just help people reduce their use of sedatives, but they also ended up having better sleep. The people who stopped their sleeping pills had a better sleep. The people who didn't stop their sleeping pills, on average, were having a better sleep. Insomnia severity, daytime sleepiness were all improved. So these were really good outcomes that we found. Just recently, we've got new data to see, okay, now that people were finished the study, the 6-month study is over, what did they do after that? I was guessing they're going to start to go back on their sleeping pills. So we looked at prescription records from across New Brunswick of the study participants to see if they were using more sleeping pills after leaving the study. I was hopeful that it wouldn't go up. I was not expecting it to continue to go down. These are the three groups. This is 12 months before coming into the study. There's variation in dispensing information about their daily use over time, but you can see that the Empower group had a big dramatic reduction. The Sleepwell group had a slightly less dramatic reduction, and the treatment as usual group who didn't have an intervention, it kind of stayed the same. Right here, after the study ended for the treatment as usual group, they all received the Sleepwell package. And out of the study, they received the package. They had a reduction in use. So even outside of the confines of a research study, we saw a reduction. So this is the reduction overall with Empower. This is the reduction overall with Sleepwell. And this is the reduction overall with Sleepwell after the study was over. So it's reassuring to me that the contents of these booklets seems to be effective at having people reassess their long-term use of sleeping pills and be able to come off of them. The takeaway from my part of this is we know that Atlantic Canada is special in its use of sedatives, in its overuse of sedatives. And we've come up with something relatively straightforward, scalable, simple to implement, which is sending the information directly to the people who are taking the sleeping pills, who have insomnia, who can then talk to their doctor or their pharmacist or another clinician about what to do next. So that's sort of the main takeaway. So I'm going to now turn it over to Sheila, who's going to give you a quick overview and introduction into the components of CBT-I.
All right, thank you so much. So I wanted to just clarify, when we're talking about insomnia, and I think we've used words like chronic insomnia, so what do we mean when we use these terms? So I want to normalize that everybody is going to experience the occasional night of poor sleep. And so, the occasional night of insomnia does not equal insomnia disorder or chronic insomnia. But insomnia, when we think about it, it's a dissatisfaction with sleep quality or quantity, characterized by difficulty falling asleep, staying asleep, or waking up too early. And while the occasional night of that is normal, when it happens more than 3 nights per week, and it has been happening for more than 3 months, despite adequate opportunity for sleep, and it's starting to impact your daily routines, that's when it becomes chronic insomnia or insomnia disorder. A lot of times what people will say to me when they come in for treatment is they'll say, you know what, it doesn't matter how hard I sleep or hard I try to sleep. When I go to bed, my mind just turns on and it starts racing. So there's that qualitative component too of this racing mind or this real strong efforts to try harder or to try and fix their sleep. So it's important to understand how insomnia develops over time. So what we have here is we have time on the bottom and we have insomnia severity over the top. And so premorbid means no problems. And then you've got acute, which is just 1 to 2 weeks, short term, 2 to 4, or 2 weeks to 3 months, and then chronic is 3 months plus. So we all have individual characteristics that might predispose us to developing insomnia. And I think even for most of the people in the room, I'm sorry to say that just by being female, we are twice as likely than men to experience insomnia. However, age equals this out a little bit, where the prevalence of insomnia increases in men as they age. So there's a little bit of victory for the women in the room, where it does equal, mostly due to bladder concerns and whatnot. But the other thing that we know is that there's some people who just temperamentally have an increased risk of developing insomnia. These would be people who may be a little bit more sensitive to stressful events, right? They have stronger reactions. They find it harder to get over things, right? They're the thinkers, right? Or the worriers or things like that. Temperamentally, it's probably been that way the whole time. But when faced with a stressor, sometimes those worries can come up at night as well. Now, you might also have various medical conditions or psychological conditions that you're taking medications or you're having to change lifestyle behaviors. Some of those other factors can predispose somebody to experience insomnia as well. So these are things along the bottom we don't usually target as a function of treatment because they're pretty stable over time. But then what happens is usually there's a precipitating event, some event or some combination of events that puts somebody over the threshold for insomnia. So I'll give you an example of somebody who came to see me. He'd had insomnia for over 2 years. And I asked him, so, what was going on when you started having sleep problems? And he said, it's because I lost my job. I was laid off from my job. I lost my job. And I said, okay, so what's happening for you right now? And he said, oh no, I got a new job. I got another job, a few months after. So I said, okay. And then when did you lose your job? It was 2 years ago that I lost my job. So I was like, all right. So the impact of the job loss was enough for him to develop insomnia. But he got another job, so he fixed that problem, but the insomnia still persisted. So how do we explain this persistent insomnia even after the resolution of the precipitating event? You can even see in the graph that the impact of that event decreases over time, right? So he got another job. It might still have a bit of an impact because there might be some like job-related worry, maybe there's some economic stress or something like that. So that doesn't necessarily go away completely, but it's not what's keeping the insomnia around. Then we look at perpetuating problems or perpetuating factors that would maintain or keep the insomnia around. A lot of these perpetuating factors make sense in the short term because people are using them as a way to cope with their sleep problems. They're trying to find solutions. How do I cope with the problems I'm having? So for some people, it might be, well, why would I get up at 7 o'clock when I just fell asleep at 4 a.m.? Right? That doesn't make much sense. So I'm going to sleep in until 10 a.m. because I just fell asleep at 4. Right? That makes sense in the short term, but I'm going to explain why maybe that's not the biggest or best solution in the long term. They might say, oh, I'm so desperate for sleep. I'm going to go to bed tonight earlier. I'm going to try harder to sleep. And I think probably the people in the room would say that is terribly ineffective. All you do is go to bed and torture yourself and end up getting frustrated and ticked off and anxious and worried and everything else like that. And then by the time it is your bedtime, you're so ticked off that it's even hard to fall asleep at your regular time. So sometimes people use sleeping medications at this time. Sometimes they, have an extra glass of wine at night. They might also cancel their social activities because they just don't feel up to it. They don't exercise anymore. They just stop doing everything because they feel so crappy. And again, in the short term, it makes sense. But in the long term, these are factors that can maintain the insomnia longer term. All of this promotes a general anxiety usually around sleep, even to the point where you start worrying about not sleeping some point in the evening where you're like, oh, I really hope I sleep tonight. If I don't sleep tonight, what's going to happen tomorrow? And so by the time you get into bed, you've already waged this war with yourself about, am I going to sleep tonight, and planning for all of the ways that you might be able to manage the side effects of that. So then what happens when you repeatedly pair something with something else over night after night after night? So imagine the scenario of you're sitting in your comfy chair in the living room. It doesn't matter if you've just had supper, but you find yourself getting snacky, right? So you end up little snacking. And so if you repeatedly pair that chair with snacking, it doesn't matter if you're not hungry. If you go sit in that chair, you find, okay, I need to do something with my hands. I feel like I need to snack. If you repeatedly pair your night or your bed night after night after night with activities other than sleep, your bed can become the trigger to elicit wakefulness. So right now, if you're pairing your bed with thinking, planning, worrying, ruminating, watching TV, scanning on your phone, reading a book, planning your kitchen remodeling, whatever else it is, then when you go up to bed, no matter how tired you are, the bed has now become the conditioned stimulus to elicit that wakefulness, right? This can happen at the beginning of the night. It can happen in the middle of the night. People will say reliably, bam, 3 a.m., I wake up, right? You can train your body to do that, just like you can train your dog to wake you up to let them go out to the bathroom at 5 in the morning and feed them, right? So whatever behaviors we reinforce, those become the ones that persist. So that's what happens we have these maintaining factors, these perpetuating factors. Usually we learn some things don't work, right? We stop going to bed earlier and trying harder to sleep because that's completely ineffective. But over time, this conditioning takes over and is one of the main factors that distinguishes why some insomnia goes on to become a chronic problem. And once we know that it has become chronic, we know that without intervention, it is not likely to resolve on its own. So I wanted to introduce two important concepts. So this is called the two-process model of sleep. And so it's these factors that come together to regulate our sleep. The first one is something called sleep drive or sleep pressure. Now, this is controlled by a neuromodulator called adenosine, which builds up in our brain throughout the day the longer that we are awake. Interestingly enough, caffeine works to block adenosine or bind to adenosine, which is why caffeine can promote wakefulness, right? So adenosine builds up in our bloodstream as we're awake, and then it discharges as we're asleep. Okay. Now, if you imagine, let's say you're a 7-hour sleeper, that's the sleep that, is what you need. And if you take 7 hours away from 24 hours a day, you're going to need the remainder hours of sleep pressure to build up before you're likely to fall asleep again, right? So if you take 7 away from 24, you get 17 hours. And if I say I'm going to wake up at 7 in the morning, right? I'm going to need 17 hours. I'm likely to fall asleep at midnight, right? Reliably. People get very bad advice usually when they're told go to bed at the same time every night, right? Because it's the morning time that sets our bedtime based on sleep pressure. So when somebody says at 4 o'clock in the morning, because they've just fallen asleep and they're supposed to get up at 7, I'm going to sleep in until 10 o'clock, right? Then it's the 10 o'clock wake up time that sets your sleep drive. So you're not likely to fall asleep if you're a 7-hour sleeper and you wake up at 10 a.m. until what time? 3 a.m. the next morning, right? So once we understand this concept of sleep drive or sleep pressure, we can start going, all right, so sleeping in doesn't work, right? Because that's going to just perpetuate the problem, all right? Now, this system interacts with the circadian alerting system. So this is one of the strongest anchors of our sleep and wake system, and it is controlled by exposure to light. There's other factors that also influence our circadian rhythm. So activity and food are also very powerful, but they're just not as powerful as light. So our circadian alerting system promotes wakefulness throughout the day. And you can see something interesting happening around the middle of the afternoon, right? Around 3 a.m. There's a little blip in our circadian alerting system right there. And so what usually happens in the middle of the afternoon, we have a period where maybe we don't feel as awake. But as you see, the alerting system, it'll just kind of rebound afterwards and we recover from that time. So people will often misinterpret this period in the afternoon of, oh, it's because I didn't get a good night's sleep last night, or, oh, it's because I ate too much at lunch or whatever. And a lot of the time it has nothing to do with those factors. It's just, a factor of our circadian alerting system being less strong during that period. So when these two factors work together, you see something quite beautiful in its harmony. So we've got the circadian alerting system promoting wakefulness throughout the day and going off to when you're sleeping, promoting wakefulness and going off. And when you combine this with the sleep drive going really high and then going down, really high and going down, when the sleep drive is really high and the alerting systems are very low, that is when your sleep window opens, right? And ta-da, right? Usually your sleep happens during that time. However, we have this other factor, our arousal system, which can get in the way and complicate both of those, right? So if we are thinking about something stressful, if we're worried about something, no matter how tired we are or where we are in our circadian phase, we can function. It's a protective evolutionary mechanism that allows us to get up and function even if we're tired. So in the middle of the night, if a car door slams, the fire alarm goes off, a baby cries or whatever, we can get up and be, our system gets activated, right? So that system can be activated by real events, or it can be activated by things we're thinking about, right? Things that we're worrying about. So if we're worrying about not having a good night's sleep and we're getting our system all activated, it can interfere with our sleep drive and our circadian system to also contribute to insomnia. So these are some examples of where people go wrong with sleep drive. So this is where it's supposed to work, right? You've got low sleep pressure in the morning. Your sleep pressure is building until your typical sleep time of 11, able to fall asleep. You discharge your sleep drive and boom, here we go again. Some of the examples of how this happens when people interfere with their sleep drive with napping, right? So somebody says, okay, I'm napping, right? This is afternoon, might be kind of, when you get home from work. So you have a little afternoon nap. So that's discharging some of your sleep drive there. So then your body has to kind of start from a lower spot in order to build up that sleep drive again. So if you were wanting or expecting to go to bed at 11, you're seeing that now you're going to bed closer to about 12:30 because it's compensating for that nap you took earlier. So that can get in the way. Now, people will often say, I don't nap, but then I'll say, do you doze? Right. And then they bashfully go, well, right. So dozing is that kind of like, unintentional kind of head bobbing in the, usually the evening hours. Those little micro sleeps, they can discharge sleep pressure as well. right? So it might not be as obvious as like a good solid nap, but they can also discharge sleep drive. So this is also what happens when I said people will go to bed earlier, right? I'm going to go to bed earlier. I'm going to try harder to sleep. So then they try going to bed at 9:30. But if they got up at their regular time, they just haven't built up enough sleep drive yet in order to be ready to fall asleep. So then they're going to spend an extra hour and a half in bed and then probably extend that even more because now they're ticked off and worried and everything else like that about why they're not sleeping. Okay, so that doesn't work. But what does work and what is one of the key factors that we use in cognitive behavior therapy for insomnia is we use this sleep drive to our advantage, because sometimes when our sleep drive is strong enough, right, our head hits the pillow and boom, we are out. And when our sleep drive is strong enough, we go into deeper sleep faster, we stay in deeper sleep longer. So even if we don't have as much total sleep as we need, the sleep is of better quality because we've got a really high sleep drive. So we want to treat insomnia. It's important to treat insomnia. Sleep is so critical for so many aspects of our health and well-being. It used to be, why do we sleep? It's like, these are all of the reasons we sleep. There's not just one. We've talked about how sleep is important for cognitive functioning, memory, attention, concentration. Our various times spent in sleep stages have very important roles in memory and concentration and attention. We have metabolic regulatory mechanisms that are working when we're sleeping. And so it has important implications for diabetes control, cardiovascular health. We also know blood pressure has important mechanisms when we're sleeping to regulate that. And then mood. One of the things that REM sleep is really important for is emotion regulation. So we're processing a lot of the things that are going on during our day, which is sometimes why our dreams are hodgepodge combinations of things that don't make sense, but have really strong feelings attached to them. So sleep is very important for anxiety, depression. We know that people who have insomnia have higher rates of both of those. So mood regulation is also important. This is the guideline that has been referred to before. It's very clear. This is an American College of Physicians guideline that says that all adults with insomnia disorder should be receiving cognitive behavior therapy as the initial treatment for chronic insomnia disorder based on a really strong recommendation. They acknowledge, though, that this should be a shared decision-making approach with patients, really talking about the benefits and harms and costs of short-term use of medications, and whether to add pharmacotherapy to CBT-I, but having this discussion first off. So we've talked a little bit about CBT-I, but getting down into what it is. So stimulus control is one of the key and most potent interventions, two of them. So time in bed restriction therapy and stimulus control. Those are the two components of CBT-I that have the strongest monotherapy evidence. Stimulus control is trying to break that conditioned dissociation between the bed and wakefulness by restricting the activities that you do in bed. The time in bed restriction is matching your sleep ability to the time you spend in bed. What happens with insomnia is a lot of times people will spend an excess of time in bed. So they'll spend 10 hours in bed, but when they start tracking their sleep, they realize I'm only getting 5 hours of sleep, right? But I'm spending 10 hours in bed to try and get that amount of sleep. And I'm going to show you something which provides an example of how we use that time in bed restriction to, get at that sleep quality. For people who have a lot of more of the physiological or cognitive arousal, we might teach some relaxation strategies. We might employ some cognitive restructuring techniques. And we do touch on the sleep hygiene recommendations just to make sure that people are aware you shouldn't be railing coffee right before bed. But most people, by the time they get to the insomnia treatment, they've already taken out anything with pleasure from their life, right? They're like, no, I've dropped coffee. That was the first thing I dropped. And I don't drink, and I don't drink coffee, and I don't do anything that makes me happy. So it's usually a systematic way of going through these various components. The first one is all about making you the expert on your own sleep. So you start by completing the sleep diary, learning what your sleep is like, and you start seeing patterns. So you start seeing, okay, you know what, when I wake up a little bit later, it takes me a little longer to fall asleep. And, so you become the expert there. And then making sure all your sleep hygiene bases are covered. And then we implement some of the stimulus control. We work on targeting the sleep drive, making sure, the relaxation and the arousal components are taken care of. And then if there's anything getting in the way, some thoughts, beliefs that maybe need to be a little tweaked, that gets worked in there as well. There's various ways for you to access CBT-I. There's what I do, the therapist guided CBT-I. There's hybrid, where people are working a little bit on their own and then they come to consult. And then there's also self-help books that have been around for a while and now are being delivered to your door, which is super helpful. The typical course of CBT-I is anywhere from 4 to 8 weeks. So when we do this in the general public, most people are saying, yeah, doc, I'm good after 4 weeks. But sometimes it's a little bit more complicated and lasts a little longer. So this is just a way for people to start getting to know their sleep. And I think one of the things with the sleep diary that you want to make sure about is that this is just your best guess, right? It's your estimate. You shouldn't be watching the clock in order to get these estimates, because we definitely don't want you doing math in the middle of the night, because as soon as you start doing math, you're engaging your head. And we also don't want you looking at your watch to tell you what your sleep data was, because there's a whole nother level of problems with that. So this is just your perception of your sleep, writing that down. And as I said, stimulus control is about making sure that the bed is only associated with sleep, sex, and sickness, right? Those are the other S's that should be associated with your bed. But what it means is that if you're not sleepy, you don't go to bed. It doesn't matter really what time it is, but if you're not sleepy, for people with insomnia, the bed is not the trigger for sleep anymore. Right now, it's the trigger for wakefulness. So you don't want to go to bed unless you're sleepy. And then if you're not asleep within a certain amount of time, usually about 15, 20 minutes, or if you know you're wide awake, then it's really about waiting for that to come again, that wave of sleep to come again, sleepiness. So it's going out to somewhere else, doing something that's pleasant, relaxing, in dim light, sedentary, and then waiting for the sleep to hit you. It's not about trying to force sleep when you're out of the bed. It's just trying to not power that conditioned association between the bed and wakefulness anymore. And so this is where I said, if people are spending a lot of time in bed, they're 10 hours and they're only sleeping 5 hours, what we do is something called squeeze out the wake, right? So we set an anchor in the morning that the person can make sure that they can do 7 days a week. So if that's 7 a.m., right, and you're getting 5 hours of sleep, we set 7 a.m. as your wake up time. And then based on your sleep ability, right, if you're only getting 5 hours of sleep and you're spending 10 hours in bed, spending more time in bed does not get you any more sleep. So we're going to really prime that sleep drive, making sure by the time you go to bed, your head is bobbing, right? And then there's going to be no mental activity. There's going to be no wakefulness. It's going to be, now we're pairing your bed with nothing but sleep. So then we squeeze out that wakeful time. We make sure that your wake up time is consistent. And then over consecutive weeks, once we've got your time in bed consistent with the time you're spending sleeping, you add on small amounts of sleep so that your sleep quality is prioritized first. And then we talk about sleep quantity. So it's not about going from 5 hours, which is not enough, to 8 hours really quickly. It is a process, because we have to recondition your mind, your body, and your bed to now have successful sleep experiences instead of frustration over time. We know that this works, right? It is, and it has been compared to sleeping medications. Sleeping medications, they work faster, right? That's usually the honest truth, right? They work faster. But then when you stop them, the insomnia comes back. We know that when we go head to head with sleeping medications, the effects of CBT-I take longer, but they're better and they're more durable than what we see with sleeping medications. And they work regardless of whether or not you have coexisting physical conditions, mental health conditions, if you have other sleep disorders. And we can use these techniques to reduce the reliance on sleeping medication. So sometimes you need a little bit of like tweakings, maybe some additional assistance if there's more complicating things, but overall, it's a very robust intervention. There's various ways and various levels of treatment that people might need. So at the bottom, a lot of people can benefit by this information that you're receiving tonight, because a lot of people go, oh, I didn't know that, right? If I knew that, maybe I could have prevented myself with some suffering, right? A little while, but self-help is at the bottom. Everybody should know this information. And then you've got your primary care physicians and you've got your community pharmacists who can also help, especially with the deprescribing. Then you've got the CBT-I specialists or CBT-I therapists, and then you've got the sleep experts. So, most people are going to benefit from those kind of lower level ones, but some people are going to need to step up based on whatever else is happening in their system at the same time. There's a lot of self-help resources that are available and specified on the My Sleepwell website. So there's a bunch of different manual self-help books people can work through. There's also available online treatment programs and even apps that people can use this treatment as well as part of their own self-help process. So I would encourage you to check some of those out. A lot of them are by fantastic Canadian authors. So I'll also mention that. And then now I'm going to pass it over to Dr. Earle, who's going to talk about treating insomnia in Newfoundland and Labrador.
I'll start with question 1 here. What do you do to help your patients and months and years of nightly sedative use? So I was very fortunate enough I'm trained as a psychiatrist, but I also worked with Dr. Garland in my training and learned a lot about sleep from her. And I went away and did some stuff. Everybody comes, I get referrals and referrals and referrals every week for people who want to stop sleeping pills. The first and foremost thing I do to help people stop sleeping pills is I fix their sleep. Because a lot of the time people have been taking a sleeping pill for months or years. They've maybe had a bit of benefit when it started, but they've noticed every time they've tried to stop it, they are way worse. So they feel dependent on it, even if they could come off of it. So before I even touch the dose, I would say people are my patient for 3 or 4 weeks, and we're starting some of the stuff that Dr. Garland just talked about. And I've got a couple of people who are doing treatment with me right now who are here. They'll tell you, we just started I started a group at the beginning of November. It's the end of November now. Right now, it's 3-4 weeks later. I'm starting to talk about helping people get off those pills. I use CBT-I. That's the treatment I'm using. And then when we are ready to start talking about their sleep being improved and then wanting to be off the pills, we do it very gradually. There's nobody who I'm cutting off cold turkey. That's not very comfortable. Some people can do it actually, and some people have very much impressed me with that. I find the recommendations I give in my clinic are to do a slow, gradual, we might be cutting pills into quarters, or even, some people are filing down with a nail file almost. The first thing I do is I help people by fixing their sleep. And then when they're sleeping well, we can kind of get rid of these sleeping pills that don't seem to be doing much for them anymore anyways. Number 2, so when people say, I've tried CBT-I, it didn't work for me, what's my approach? The first thing I do is I listen to these people. And then I probably ask a few follow-up questions, because a lot of people have been given a sheet, maybe not a sheet like the one we're handing out here tonight, but a sheet, one of these sleep hygiene sheets. And that might be what they've thought CBT-I is, and they said, I've tried CBT-I. I stopped caffeine. I don't go for exercise right before bed. I get rid of the screens. I'm like, okay. So I make sure that what they've looked at is actually CBT-I, not something they maybe have confused for CBT-I. I ask about, how long they were doing it. Sometimes I had one patient that Sink into Sleep book, which I actually gave about 20 or 25 copies of that book to the public library network. So most of the libraries in Newfoundland have one. I'm working my way up to all 97 divisions, but for 30 or 40 bucks each. I listen to people. I've had people come to my clinic say, I read that whole book, didn't work. And I say, did you follow the steps week over week over week? They're like, no, I read it start to finish and it didn't accomplish anything. And it's a process like was shown here. It's not something you can't do CBT-I in 2. There's the odd patient who they change like one key thing and they see a miraculous improvement. The average patient, it's a 4 to 6 week journey to kind of really start feeling that robust, sustainable change in their sleep. When I have people who maybe they might have been my own patients, they might have come back a year later and said like, didn't really work last time. Though what I'm seeing there is sometimes people have tried CBT-I, what might not have been the right time for them. They might have had surgery in the middle of doing it. They might have been recovering from grief or loss. They might have been struggling with something I've had patients say it didn't really work last time because I was drinking a lot and I didn't want to tell you about that. So sometimes there's a substance use issue, a mental health issue, a physical health issue, or an external stressor that because they're kind of right in that first bar on that bar graph, the acute insomnia, in acute insomnia, it's the stressor that's keeping them awake. Stress and sleep are diametric opposites. They don't coexist well. You're either stressed or asleep. You're not tend to be both. Though nightmares really throw you through a loop in that equation. We try and find what either physiological stressor was there or external stressor. And maybe we're going to try CBT-I again with them at another time when those barriers are there. Sometimes there's more complexity to that. Dr. Garland's actually got a book that she edited, a textbook. You don't need to run out and pick up this one, though. If you're looking to learn the therapy, as I know there's some social workers and nurses here, it's a great resource for advanced practitioners. It has a whole chapter on approaching CBT-I in people who have tried CBT-I before. Those are my own approaches. There's also some different therapeutic techniques we might mix in, but in my experience, they might have been confused about what CBT-I was. They might have been doing it unsupported and they might benefit better from support, or they may have just tried the steps and tried them with good effort just at a time when they were unlikely to maybe succeed. And when I see a new patient, I do an interview with them and I try and figure out if now's the right time, and I give them my best guess on, okay, sounds like this is a really busy time. Do you think the spring would be better? And sometimes we choose to wait because we want to start people off with the best chance of success. Question number 3. What part of CBT-I do your patients find the most challenging, and what is your advice? So I think this is a trick question because the hardest thing about CBT-I, first of all, is finding out it exists. I've had patients who had insomnia for 25 years and they never heard about it. So that's why I did an earlier talk this week. Dr. Garland did an earlier talk this week. You're a week ago from doing your last one, I think. But we're trying to spread the word of this stuff because hearing about it is the hardest thing, and then the next hardest thing is finding someone in your area. I'll talk about the Newfoundland. I think we're at a better time than ever because we're training folks locally. I'm training 2 social workers now and psychiatry residents, and you've got an army of students. So every year we're getting more therapists in Newfoundland who know this, and every year we're telling more people about it. In the actual doing of the therapy, you read that, you hear people saying, oh, you want to wake up at 7 and you get in 5 hours. People think staying up until 2 is the hardest thing. I'll be honest, you're already staying up until 2. The hardest thing I find people, they come in, they're adherent with the schedule, and I see these wake ups in the middle of the night and say, did you get out of bed? I think that's the hardest thing, especially this time of year. In the summer when it's warm, it's a bit easier, but it's so dark, it's so cold, and without a lot of planning, it's really difficult to, I say, get your carcass out of bed, because that's what it feels like in the middle of the night. That's the hardest challenge I find. It's the hardest thing for me to get people to do. I think the sleep restrictions seem scary, but in the actual doing of it, you realize, wow, this actually feels a lot better. But I find stimulus controls and getting the phone out of your hand. I feel some people sleep with the phone claw. That's a hard one too, or breaking up at the clock. Stimulus control, I think, is the bigger shift for a lot of people. Number 4, insomnia treatment. What does the ideal education of healthcare professionals look like? I know that not every healthcare professional, not every family doctor is going to have the time, the capacity, or the interest in necessarily delivering this therapy. I think the start is we need to have them know about it. I can guarantee you, I took over teaching at the medical school some of the sleep curriculum when I came here a few years ago. The sleep lecture didn't have the word, I don't know if it had the word CBT-I in it, but this is because this is, every year the knowledge of this is growing, right? And that's not just a MUN issue. I look at when I started taking over, I asked a bunch of other schools for their curriculums to look and do a comparison, and it wasn't even making it in first line therapy. The single treatment that is recommended by pretty much every insomnia guideline internationally sometimes isn't even on the slide. I think we are, some of my mentors are here in the room actually at Flattered. They're talking about this in the rooms, they're here, they're hearing about it. So doing talks like this, not just for you folks, but also for doctors, social workers, nurses, putting it in our curriculums, putting it in our clinical placements, because I can find they forget a lot of stuff on the slides, but when they see it in practice in clinic, when nurses in the cancer unit are handing out cards about this and their students are there seeing it, when family doctors are prescribing it, when pharmacists are providing this advice in these handouts kind of at the counter. I think the ideal health professional education is exposure. I would love it. I offer it to every psychiatry resident who comes through to come and see a group and sit in on it and even try and coax them to kind of running the show. I know that's not feasible for everybody, especially from a time perspective, but my answer is I want everybody when they're getting their cap and gown to at least have the acronym CBT-I in their head, and I call it a clang association, just automatically associate the words chronic insomnia with CBT-I rather than with a prescription pad. I say this, I don't say this too loudly, but it's been 5 years since I'm a full-time psychiatrist and sleep, I do some other stuff in sleep, so I can't say sleep is all I do, but I haven't prescribed a sleeping pill in over 5 years. And I wish that my residents could say the same thing at the end of their training. Number 5, from what you heard here, is there anything you want to comment on or add? The biggest thing for me is looking at our local rates. We know there's scarcity of all sorts of types of doctors and health professionals here. It seems like the access we are getting is not necessarily the best thing for our patients. And I hope this is a little bit of a call to action, not just for us as receivers of care, but also the people who are administering the care to know, that there's hope, that there's options, even if, every clinic has wait lists, you move through them pretty quickly though. And even knowing there's self-guided recommendation, even knowing the books at the library, right, I think is enough to give some people access. That's the biggest thing for me. Seeing how many Newfoundlanders and Labradorians, seeing how many people in New Brunswick, we're second. We're not first in rates of prescribing, but when I think of, if my parents had insomnia, if my friends had insomnia, I would be offering them this before that, and that's what I'd be offering you all as well, is this type of treatment, and I think that's important. Up to a third of people, like 30%, work some form. It might be on call once a month. It might be, full proper night shifts, but it's quite common. And I work in healthcare where it's almost ubiquitous. So I gave a talk to some two of the classes of medical students on Tuesday about this. The first thing I'll say is there is hope. People can both learn how to sleep well with their shift work and it doesn't have to be as damnable as it feels right now. There's not one single tip for shift work. There's actually a phenomenal resource developed by a group in Quebec called Working the Night Shift. It's a 4-part kind of module that's online, completely free. It goes over a lot of components of, really, it kind of depends on how your shifts are. If it's one overnight a week versus I'm doing a block of days, then a block of nights, the approaches are different. If you're doing the sporadic night shift, I think it's about, my biggest tip to the residents is don't get home from your 24-hour shift and sleep like 8 hours immediately. I say get a little bit of sleep to kind of catch up, and then try and preserve your sleep window that you have at the night to kind of keep that momentum so that you're not kind of doing the exact opposite of that sleep drive graph and extinguishing it all in the morning and then you're wide awake at night because you're not at your 17 hours. But I also say it's not a day off, it's a day to sleep if you're off the next day. So not to schedule a ton of activities, like being pretty low activity that day after, getting some sunlight during the day is going to help kind of reset the circadian rhythm after being up all night. If you're somebody who works blocks, like you're going either to Alberta or you're working like, a run of days, a run of evenings, a run of nights, one of the best ways to do that is exactly as I outlined it. Instead of necessarily, kind of being all over the schedule, a day here, a night there, a day here, a night there, doing your schedule as a run of days and maybe your earliest days at the start and then moving down towards later days. Then if there's an evening, I think of my emergency room colleagues. So there's like a day shift that's like 8 to 4. There's an afternoon kind of 8 to 8. And then there's almost like an evening 4 to 8. And then there's the notorious overnight. Moving through that schedule in either a few days each or even a full week each is the best way to do it. That might not necessarily be feasible with a workplace. We both work with people and with their workplaces to come up with, reasonable schedules that can keep people working and working well without necessarily have to be completely off of nights. There is a shift work sleep disorder that is, rarer than the typical difficulty sleep disorder. There are a very minority of patients, might have to be off shift work for medical reasons, like having bipolar disorder. But a lot of the time we can work people and work with their employers to kind of figure that out.
There's something called sleep architecture, where you do go through these kind of 90-minute typical cycles where you're going to progress deeper and deeper in from stage 1 sleep, stage 2 sleep, and then your stage 3, which is your slow wave delta sleep, come back up, have a little bit of REM, go back down, come back up, go back down, come back up. And in the beginning of the night, you spend more time in slow wave sleep, the deeper sleep, the one where your brain waves are really wide and spread out. And that's when your body is getting more of the physical repair and restoration. That happens more in the first kind of chunk of the night. And towards the end of the night, your brain is spending more time in REM, or rapid eye movement sleep, which is more about like the emotion regulation and the cognition. So your body is kind of splitting your night already, and it's interspersing these kind of 90-minute periods with periods of wakefulness, right? Or at least easier to arouse, right? So you might have these wakeful periods in order to shift your body around or be able to, adjust or, something like that. So we do have these awakenings. We might not be aware of them throughout the night. I would say the less we try to optimize our sleep, the better it is, right? I think humans have a tendency to get in there and try and tinker with things and make things worse. So our body has developed this sort of pattern of cycling through our sleep stages, having some concentrated at the beginning of the night, having some concentrated at the beginning or the latter part of the night. And it's been doing that forever, right? It knows what it's doing. So we don't necessarily need to go in there and try and be like, I'm going to manipulate it by going to bed here or there or switching things up. I'm just going to try and set myself up in a sleep period that suits my circadian rhythm. I'm going to make sure my external and my internal environment are all conducive to sleep, and I'm going to let my body do what it knows how to do. That's a long answer, but I hope it's a good one.
I'll talk about melatonin separately, and I'll put all of the other medications that you mentioned sort of together. So over-the-counter medications, the ones that tend to be for helping you sleep, especially if you've got a cough and a cold and it says nighttime, then it probably has a sedating antihistamine in it. And some of the prescription medications that we use, one of the pharmacologic effects is a sedating antihistamine. So it might be for a different reason, but effectively you're getting a little bit of sleep pressure from the medication is because of its antihistaminic effects. But there's other mechanisms of how these drugs cause you to feel sleepy. But there's a big but here. None of them are first-line therapy. None of them are clearly better than the others. They all fall into the same issues that we talked about earlier with some of the side effects that I went through. First-line therapy is always going to be the same answer. It's CBT-I. Second-line therapy is still going to be any of these different medications, cannabis, alcohol, some sort of lavender or peppermint or something along those lines. I do talks like this often in front of audiences of doctors and pharmacists, and then they come up afterwards and they go, "Nice talk, David. I got a question. What's the one you would recommend?" I know you don't want anybody to hear this, but what do you actually recommend? Trazodone's not a bad one, right? And I always refuse to answer the question because it distracts from the bigger message, which is the message that you've actually heard tonight. So melatonin is different, and it's different because it doesn't work for run-of-the-mill chronic insomnia. So melatonin is an effective medication for some sleep problems that are not insomnia. It's not a bad idea for jet lag or something else that's actually shifted your circadian rhythm. And you can do that by going to bed super, super duper late. But some people just have this condition begin on their own. And so we can use melatonin to help with that. So it's not actually called insomnia because it's not insomnia. And jet lag is not insomnia. It's a condition because we've gone to a different place where the light shows up at a different time. So I just want to make it clear that I actually think melatonin has a narrow, small little place for sleep problems, not how it tends to be seen or used.
I attended a wonderful lecture a couple of years ago, and I actually bought the book of the guy who gave it, and it was a history of sleeping pills. And it started off, he said, with like the bromide salts and chloral hydrate back, 100 years ago. They said they were perfect and they fixed organic insomnia. And then they realized they caused dementia and made you have a stroke and all this stuff. And they said, and then the benzodiazepines, so the ones that end in PAM, like the clonazepam, lorazepam, oxazepam, temazepam, then they came on the market and they were much safer and everybody got put on them. It's probably, either your parents, your grandparents, probably had, when my grandmother died, I found like a bottle of one of these drugs that I was like, oh my God, this is who gave her like 300 pills of this? And, when they came out, they were so safe and much safer than the old ones. And then over the years, a lot of the harms of sleeping pills on that slide are related to that. You can develop dependence, you can fall, you can, cognition concerns. And then in the 90s, we had the Z drugs coming on the scene. So that's the one we talked about tonight, zopiclone, and the other ones that begin with Z. And they were so much safer, and they had all these beautiful ads with, Lunamots and sleeping people on them. And they were so much safer than the benzos, and they switched. And now, we're at the stage where these have been out for, 20 years. And now we're realizing it's the equivalent of a blood alcohol concentration for driving 23 hours later the next day. 11 hours. It's there's the concerns are coming out. So, the unfortunate thing about new stuff is just like whenever they come out with a new type of paint, you might say, oh, okay, great. It's, lead paint was great when it came out, and then we realized all the problems, decades later. Our concern, I think I'll speak for us all, is, maybe these, maybe they're better. Every other thing that's been on the market for like 100 years, once we had enough time and data, we started seeing the concerns. Not really going to reverse the underlying psychological and cognitive and behavioral disruptions that we see. It's not changing the behaviors of lying in bed worrying. It's not changing, the time on the phone and stuff, which is, feeding into the problem, as much as the initial stressor. These medications work by sedating you, so that they're approaching that stress versus sleep side of the equation by lowering stress. A lot of them can be used for, anxiety attacks and stuff as well. Or anxiety or depression for some of the antidepressant ones. They're affecting the stress equation, but they're not really doing things to promote natural, healthy sleep or the way our body's designed to sleep, which is Dr. Garland covered exactly how CBT-I is. We're really just taking the science we know of sleep and saying, well, these are the things that improve your sleep drive, and these are the things that improve your circadian rhythm. And if we do them all at once, we're going to have the best chance of improving your sleep. So I proceed with caution is what I'm saying. And there's a bunch of drug interactions on these ones that the older drugs don't have. So you've got to watch out for some of those, for the doctors and the pharmacists and stuff in the room, like the CYP enzyme interactions. Some of them interact with some of the cardiac meds. So they're not a panacea, certainly.
I alluded to it in my talk, is that we can use these therapies in other populations that might have conditions that already make sleep difficult. So, chronic pain conditions, other conditions like you mentioned, tinnitus, which, is torture. So this would be the level at which, in most cases, working one-on-one with somebody would probably be a little more helpful, although there are self-help books that deal specifically in improving insomnia in patients with pain and anxiety and everything else. But when you have these other conditions, so I work a lot with people who have insomnia that's comorbid with cancer. And I think if we can improve sleep in people who are undergoing cancer treatment, using CBT-I techniques, we can do it in a lot of other populations, even implementing it in hospitals. So we've done some really good randomized clinical trials in patients with comorbidities. Some of the effect sizes of treatment are somewhat smaller, but they're still better than what we see with sleeping medications. It's just, you want to look at the whole person. You want to take into consideration how their pain is being managed. If there are other behavioral or lifestyle factors that are both going to target the insomnia and the pain, you're going to work those in. So it is still an incredibly robust treatment in patients with other physical or mental health conditions as well.
We haven't done research to answer the question with good insights, and I'd be happy to hear what other people think, but I think it's sociological. I think there's a whole variety of factors, Part of it is pharmacological. If you take a medication that's hard to come off, and then somebody else starts to take it, it's hard to come off, and somebody else starts to take it, it's hard to come off. And then you are getting trained as a healthcare provider, and you're seeing all these people taking your healthcare colleagues, those patients are taking it. You go, okay, I guess we use medicines for this problem. But if you go to Saskatchewan, you don't see it as much. So I think it's a part of the culture. People see others taking it. My sister takes it. My brother, my mother takes it. I guess I'm having some trouble sleeping. Should I go see my family doctor and ask if I can get on Zopiclone? You know, if you don't know of the alternatives, that's what happens. And if you see everybody do it, whether you're a healthcare provider or you're somebody who just is a citizen in the town, maybe that's why we end up having higher rates here. And if you don't see people doing that, then you don't think to ask for it or you don't think to offer it. It's a very simplistic view on it. I don't have a more elaborate view on it. And we want to know a little bit more about that to better understand why it's happening more here. But that's my perspective on
it. It is really like from doing science, it is very difficult to prove causation. Like we actually like the test for proving causation, we still haven't really proved that smoking causes lung cancer because you actually have to take people and randomize them. And these are things you can't just randomize people and say smoke for 20 years. So the best we can tell, there is some concern for some of the sleeping pills in affecting cognition. Certainly while you are taking them, they can affect cognition. We don't use words like permanent damage. Coming off them, we can actually see an improvement in cognition. Sleep difficulties, similarly, when you are sleep deprived, we see, impacts on your functional, that day or the next day cognition. I will say, I don't think that there's necessarily the long-term side effects of insomnia as far as medical, we think it's a risk for hypertension. There's a few things, but it's more kind of well-being type indicators. I don't think we're getting in the territory of permanent brain damage type thing. And I think that's feeding into the negative cognitions people have around insomnia, like the catastrophic thoughts of if I don't sleep tonight, I'm gonna, X, Y, and Z. What I tell my patients who come to me with these worries, like even people who have seizure disorders and they know that when they don't sleep, they're at higher risk but you're doing the best treatment available to improve your sleep in a healthy, non-medication based way. And, looking forward, your trajectory is only going up. So, I try and work with people to see the positive impact of the change and addressing these concerns. And CBT-I fixes, if you're concerned that sleep impairment or sleeping pills is going to affect your memory or your health, CBT-I is going to improve your sleep and help you get rid of the sleeping pills. So it's the answer to both of those concerns. So I really think it's just another arrow pointing towards a reason for doing CBT-I if you have that concern. But the medical literature hasn't really established a clear cause, but definitely these medications affect cognition while you're taking them. I see people with glazed over eyes in my clinic all the time because they're on so many sedatives.
I'll just quickly add, these are being recorded. And the previous one, which was in Fredericton, had George, who's 80 years old and stopped 35 years of sleeping pills. And he talks about the cognitive change. So you can watch the video. It's also, George is on the homepage of My Sleepwell, and he tells his story in French. The recording from last week that's on the homepage that you just have to click on is in English, so you can listen to it either way if you're interested.
So I can speak specifically to some options for CBT-I treatment within Newfoundland specifically. And so, any of these options that we've talked about here online are available, right? So whether you download them, whether you get them from the library, but we do have some in-person treatment options. So I run a virtual CBT-I clinic out of the Doctor of Psychology training program. So we offer CBT-I to community members. The services are provided by doctoral students who are training with me. They're virtual. Sometimes they're supervised or recorded. So people who are interested in this can avail of it. They just have to know that there's a training component to it. So they have to be okay with that. But because there's a training component, there's not a cost associated for that one. So that's one insomnia clinic. And then there's, the next level up, which would be seeing individual providers. So, there's myself, referrals to psychiatry. Those ones maybe tend to be a little longer of a wait, a little more complicated, but the first line ones would be, the books, and then the insomnia clinic, and then kind of higher up. And so that's only been available, I think, in the past 4 years since I've started it as a way to increase access, because prior to that, there was 2. And so now we're trying to expand that out.
I'll just say my clinic is I run mostly a group therapy program. I run a group every 2 months and probably twice. Those are all virtual. They're Thursday evenings. And I run about 1 or 2 in-person groups a year. Where I'm a specialist, I just need a referral from a family doctor or a nurse practitioner. That's locally. And there's the online stuff, which you can see on the screen here is that's all. There's all sorts of programs online. It depends where you are on kind of the change ladder. It's what can I do if I'm not ready to necessarily take a whole CBT-I program. If you're, I tell all of my patients in CBT-I or not, if you're lying awake in bed, awake for more than 10 minutes, you're just feeding into the insomnia and making it worse. It's like people who have depression want to stay home and do nothing. That makes their depression worse. People with anxiety want to stay home and avoid things. That makes their anxiety. Staying in bed, which is what insomnia tells you to do, if you're not sleeping, makes it worse. So if you're just wondering what to do tonight, get up, go find somewhere else comfortable. Really follow those stimulus control steps if you just want something you can do tonight. But in the kind of bigger picture of CBT-I, the real thing that's going to fix it is squishing out that awake time, like Dr. Garland said, by doing sleep restriction paired with stimulus control and other interventions. But that's, you want to look at a period of 3 or 4 weeks when you have time to do that. And a lot of patients right now might say, oh, I want to start that right after Christmas or something. They don't necessarily, but I think the best time is now personally. So tonight, I would say get up, do something else, wait until you're feeling sleepy, like head nodding kind of off before going back to bed. Long term, that's something that CBT-I fixes.
And I will add to that because that's going to come with a lot of anxiety, right?
Oh.
Because people will be like, well, if I get out of bed, I'll never fall asleep, right? Maybe at least I have a chance, or at least I'm resting, or all of these other things that people tell themselves. I think probably the more helpful thing to tell yourself is I'm going to sleep really well tomorrow night because my sleep drive is going to be so strong. So at least if I'm awake, I might as well not torture myself, right? I might as well not lay in bed flip-flopping like a fish and getting stressed out and anxious and everything else. I'm just going to go somewhere else and do something pleasant, relaxing, non-stimulating and dim light. Even if I stay in that spot for 3 hours, at least I'm doing something and not just stressing. And then I'm going to be tired, but that's okay because people with insomnia know how to cope with being tired because that's the consequence that they've lived with. But that sleepiness is going to be the power that helps people fall asleep more quickly and sleep more deeper and get a better quality of sleep the next night. So it's almost like you got to take a bit of a hit in order to get over it and onto the other side where you're moving outside of insomnia.
These are my colleagues. I'm hoping that we can do interventions that support people coming to you and saying, I'm ready to come off sleeping pills or I'm ready to do something different about my sleep. My interests are in helping people directly access CBT-I, so moving down on the on that pyramid or hierarchy, if you will. So I'm hoping that we'll be able to do some things along those lines.
What parasomnias are their movement disorders during usually the first part of the night. So movements like sleepwalking, sleep talking, sleep eating, sleep sex. There's lots of complex behaviors people do when they're in slow wave sleep. And I think the short answer is the best treatment for parasomnias is prevention, because parasomnias are more likely to occur when people are sleep deprived, because parasomnias occur out of that slow wave sleep, which happens more in the first half of the night. So if people are really tired and then they go into that deeper sleep stage and they stay in that deeper sleep stage longer, that's when the parasomnias are more likely going to occur. So prevention is a bigger key, making sure that they're getting adequate amount of total sleep time as a way to prevent it, and then also just safety. So that's what I would say is making sure that people are protecting themselves.
And something like as a sleep physician, something we really work hard to find is the cause. A lot of parasomnias are induced. It could be by drugs or alcohol. They could be caused by snoring or sleep apnea symptoms. I've seen tons of people have parasomnias emerge when they started a sleeping pill. So I play the detective game. My first thing is to try and get rid of as many causes as I can. Some people just, who had a kid that sleptwalked, right? It happens when you're 10 years old or so. It can just happen without any specific cause. First, we want to get rid of, I want to find the causes. Well, I give the safety recommendations day one, because until I find the cause, it might take a month or a year to get a sleep study, depending on what province you're in. So certainly addressing any causes, doing the safety pieces, and there's a huge behavioral component as well and psychological component. So seeing a sleep psychologist or a sleep psychiatrist is probably going to be better bang for your buck than maybe somebody's just going to give you a CPAP and not really counsel you around it. That being said, my colleagues in respirology are treating sleep apnea, which is preventing tons of parasomnias. Some of the principles of CBT-I can actually help, but I don't think going through sleep restriction could temporarily worsen it, certainly. So, and it depends on the parasomnia, because like nightmares is technically a REM parasomnia, I guess, and they're almost fixed by CBT-I a lot of the time. And then there's some that are related to like dementia that we end up treating more medically, not with sleeping pills, but with other stuff.
So I'm happy to say that they've also done CBT-I trials in women with difficulty sleeping as a result of menopause, and it also works in women with menopause. menopausal related sleep problems. So the question was though, why? So we know that sleep does change as we age, not as much as people do think it does, but as we age, our sleep need decreases somewhat, but it's not substantially. So if you were a 7-hour sleeper, you don't automatically become a 5-hour sleeper, but you tend to maybe require somewhat less of a total sleep need. Now, though, I think we're only really starting to appreciate the full impact of the hormonal effects, both like monthly, but then also when that is no longer a big part of a woman's experience and the impact of those hormonal changes on sleep. So a lot of it comes because of the hot flashes. And so there's now better evidence on ways to manage those hot flashes, but then there's also ways to manage hot flashes in the middle of the night. So one of the best ways is actually doing like a diaphragmatic breathing exercise where you slow your autonomic nervous system, and that can actually reduce the duration of the hot flash. There's ways that you can use cooling pillows around your head in order to reduce the frequency of the hot flashes or reduce the severity of the hot flashes, making sure that the hot flashes aren't completely just drenching you in sweat, so certain fabrics. So there's ways to manage it, but it certainly is one of those reasons why we've got extra difficulties in women who experience menopause. Yeah.